Welcome to postpartum nursing. We're going to talk about how to prevent complications, some of our discharge teaching, but first we're going to start out with our assessment. It's the routine assessment that we do on all adults, but now we have just a few more items that we need to do with this postpartum patient, and that's what we're going to talk about. Remember that you can learn a lot about your patient just by talking to them. How are you feeling? How's it going? Congratulations. Tell me about your baby. They'll tell you all kinds of stuff, and you can get all kinds of history without going in and acting like you're trying to check off a checklist. Have you had a bowel movement? Are you peeing? Talk to them, and one, you're determining their level of consciousness and their awareness because they're answering appropriately. And then you don't have to ask, do you know what today is? Because if I asked y'all right now, would you know what today was? Some of you might have to look at your watch to be for sure. We have busy lives and we forget. And so it's either Monday or Tuesday. I don't know. Remember, when you're doing your postpartum assessment, there's more to this mom than just her fundus. It's a holistic assessment, and that includes looking at her prenatal history, looking at her labor and delivery history, looking at her labs. Does she need any immunizations before she leaves, such as rubella, the flu vaccine, or DPT? Does she need RhoGAM? How are you going to know if she needs RhoGAM? You're going to have to look at her labs and her baby's labs. Our physical assessment for our moms, it's called a bubbles assessment. And it stands for breasts, uterus, bowel, bladder, lochia, and episiotomy. Now, sometimes we add some extra E's on there so that we make sure that we get everything covered. E is in extremities, or does she have edema? For an epidural, is she recovering from her epidural? What's her epidural site look like? And then her emotional status. So the first B in our bubbles is talking about breasts. Are they soft? Are they filling, which means they're starting to get a little bit firm? Or are they engorged, which means that they're pretty firm and pretty hard? We want to find out what stage of milk development she has. Does she have colostrum or true milk? I don't know. I haven't seen it. Have you seen any around your baby's lip while they've been nursing? Colostrum is a very nutrient-dense form of the first fluid from the breasts. Milk comes in, true milk comes in day 3, 4, and beyond. We're probably not going to see that with our vaginal deliveries, but we might see that, or we might see that it's starting to come in with our C-section moms who have been with us for 2 to 3 days. We want to look at their nipple structure and see if they have any pain, if they have any damage. Now, we can do a breast assessment without uncovering her. If she has a bra on, all we're using is the back of our hands to feel whether her breasts are firm or not. We're not doing a breast exam. We can move her bra out of the way and look at her nipples without completely exposing her. And occasionally I've been in a room with a student who has wanted to take her gown off and put it down around her waist while they listened to breath sounds, while they listened to heart sounds, and when they inspected the nipples. And my expectation is, if you're going to do that to the patient, then you need to do that. And if you wouldn't be comfortable doing that, then please afford the patient the privacy. Look without exposing and without having to have her completely bare-chested while you do your assessment. We're going to teach her what breast care is, and that means that we're going to teach her that if she's breastfeeding, she needs to have a good supportive bra on. If she's bottle feeding, she needs a nice snug bra on, like a sports bra, that's going to do some compression of her breast tissue, and that does that feedback loop and tells her body that she does not need to produce as much milk. If she's breastfeeding, she does not need to wash her breast or use soap on her nipples, nor does she need to do anything prior to putting baby to the breast. The breast secretes its own type of antibodies on the surface of the nipple that will protect the nipple and protect the baby. Remember, when you're listening to heart and lungs, when you start your assessment, then go ahead and listen to her bowels while you've got your stethoscope out. That way you've got all the listening done. You can put your stethoscope back around your neck, and you don't have to worry about, did I listen to bowel sounds before I check her fundus? Her fundus is the top part of that uterus, and we want to find out, is that firm or is it boggy? Firm, it's going to feel like a little softball in there. If it's boggy, it's going to feel pretty mushy. We want it firm. When it's firm, it prevents postpartum hemorrhage and prevents a lot of bleeding. If it's boggy, then we need to massage it until it gets firm. Where is it in relationship to the umbilicus? Is it above or is it below or is it at the umbilicus? And one of the best ways to determine where your fundus is use the outer edge of your hand and start at the umbilicus and kind of rock your hand back and forth, and you should be able to feel that fundus under it. And then is it midline or is it shifted to one side or the other? We want it midline. If it is shifted to one side or the other, that means that bladder might be full, but it also means that uterus can't clamp down when it's not in its normal position. So it increases the risk of her bleeding. We're going to teach mom how to palpate for herself. Here's what we're feeling when we do this. Do you feel this right here? Every time the TV show goes to a commercial break, reach down and just check to make sure your fundus is firm. And if not, show her how to massage. And this is an example of how you massage. Do you see this hand down here? It's supporting right above the symphysis pubis. And then she's using the edge of her hand to locate where that is. Since I'm thinking this is probably her umbilicus, I'm not positive, but I'm thinking, then this fundus, the top of this uterus, is above this. And if you have your hand like this and kind of just rock it back and forth, you should be able to feel where that upper edge of the fundus is. You're going to support here so that you don't push here, especially if you're massaging, and then push this uterus inside out and have that inversion that we've talked about. The second B is about bowel. Listen to the bowel sounds before you assess the uterus. Her stomach should be nice and soft. You need to document, is it distended and soft or is it distended and firm? What's the tympany of it? Has she had gas? Has she had a bowel movement? When we ask, when was your last bowel movement? If they tell us that it was prior to delivery, we're not going to get real concerned about that. We're going to ask her if that concerns her. Does she feel uncomfortable because she hasn't had a bowel movement? And a lot of times when you ask them that, they're going to say, no, that's just my normal. Teach them like we did in the antepartum time frame. Increase their fluids, increase their fiber, help them understand about getting up and ambulating. It will help with the gas pains. It will help with stimulating that bowel to go. That ambulation is really important when we're talking about our C-section moms, because our C-section moms, they want to stay still because their stomach hurts. But sometimes their stomach hurts because they're full of gas. And if we can get them up ambulating, it will help them pass that gas a little bit better. Remind them to use their peri bottle after they've had a bowel movement or after they've voided, and then to pat dry when they're wiping, because their bottom may be extremely uncomfortable. The second B is our bladder. Is it full? Where was our fundus? Is our fundus in midline like we expect it to be? Or is it off to one side or the other? If it's off to one side or the other, that indicates that bladder might be full. Can you palpate it? When she's voiding, does she feel like she's completely emptying her bladder? No, I feel like I go, but when I'm done, I still feel like I need to go some more. That's called urinary retention. What is the quantity, the color, and the clarity? A lot of times in our postpartum moms, this is very difficult to assess because they also have lochia in the urine. So it looks very bloody, but we have to be careful that we're not calling it hematuria. It's urine that has bloody lochia mixed with it. Dysuria. Does it hurt to urinate? And this can be a tricky assessment in our postpartum moms because their bottom is sore. They've had trauma to the urethra, to the vaginal opening. When they urinate, if they have a little bit of raw right there at that meatus, then the urine might cause that to burn. But it's because it's urine on irritated tissue. It's not because it's burning when she urinates like a urinary tract infection. We want to teach her about the diuresis that's probably going to happen in these first few days postpartum. She's going to urinate a lot. She's probably going to sweat a lot. It's to help get rid of all that extra fluid that she put on when she was pregnant. Sometimes our moms are completely amazed that their blood volume doubled during their pregnancy. They're not aware of that, so they're kind of shocked and in awe of how unique their body is in preparing for this whole process. Again, remind her to use her peri bottle. We can use that for cleansing after urination and after a bowel movement, but sometimes we can also use it to help her stimulate the stream to start urinating if she's having difficulty. Our mom should void spontaneously within 6 hours of either delivery, if it's a vaginal delivery, or 6 hours after the Foley has come out if she had a cesarean delivery. If she hasn't voided within 6 hours, most protocols say that we need to straight catheter. We don't want that bladder full. We don't want it to displace that uterus and increase the risk of a postpartum hemorrhage. Sometimes our moms can't feel that their bladder is full because of the remaining effects of their epidural or maybe because of some of the trauma from the childbirth. So we need to do all the things that we learned in med-surg to help her be able to void in those first 6 hours. Running the water in the sink in the bathroom, that peri bottle squirting water over her perineum. We're going to measure her first 1 or 2 voids. Some hospitals say the first one, some hospitals or docs say the first 2. We want at least 150 mLs out. If we have our 150 mLs out, then that implies that we have adequate bladder emptying. But again, we're going to keep an eye on the fact that her uterus is not displaced and we're not palpating that bladder. Lochia. We're going to talk about whether she has rubra, serosa, or alba, and you're going to document which one of these this mom has. You need to know this so you can teach your mom what those normal changes are. We're also going to document how much she's having, scant, light, moderate, or heavy. Is she having any clots? Does it have any odor? We're going to teach her to change her pad every couple of hours. She's going to change it at least every time she goes to the bathroom. Even if it's not soiled, use the peri bottle. We're going to teach her about the change in her lochia over time and how much is too much and when she needs to report it. Here's a sample of several different pads. This is scant bleeding. This is light bleeding. This is heavy bleeding. And heavy bleeding, when we're talking about saturating a pad, we're talking about a saturated pad that cannot contain anything else. So while this is very heavy, I would not call this saturated because there's still more of this pad that could absorb something else. Estimating lochia is a very hard thing to do because a little looks like a lot. If you have a little lochia in the toilet, it stains everything in the toilet, so it looks like a lot. And we tend to underestimate how much lochia somebody has. Postpartum hemorrhage. This is one of the reasons we're so concerned about the type of lochia and the amount of lochia. About 5 to 8% of our vaginal births have a postpartum hemorrhage. It accounts for about 25% of our maternal deaths. We consider postpartum hemorrhage greater than a 500 ml blood loss in a spontaneous vaginal delivery or greater than 1,000 mLs in our cesarean deliveries, or a 10% decrease in hematocrit between their admission labor and their postpartum hematocrit, or the need for a blood transfusion after birth. And we tend to do blood transfusions based on symptoms rather than on lab values. If mom has air hunger, if she's extremely pale, if she's having severe orthostatic hypotension, then she may get a blood transfusion regardless of what her H&H are. If she's saturating a perineal pad in 15 minutes or less, then we consider that highly significant. And then we probably want to start weighing her pads and the chucks under her so we can obtain an accurate amount of output. The cause of early postpartum hemorrhage is uterine atony. That's when that uterus is soft. It is not firm. So we want to do a gentle massage to firm that uterus up. And we're going to massage that kind of in a circular motion at the fundus. As soon as the fundus is firm, you need to stop. If you continue to massage a firm fundus, because of the nature of muscle fibers, it's going to tighten, tighten, tighten. It can't tighten anymore, so it has to relax. We don't want to massage that fundus so much that we massage it into a boggy uterus. It accounts for about 90% of our postpartum hemorrhages, and 2/3 of our postpartum hemorrhages have no predisposing factors. And we've talked in previous discussions about what's going to increase the risk of postpartum hemorrhage. Most of our postpartum hemorrhages don't have any of those predisposing risk factors. Uterine atony, what are those risk factors? We've discussed previously in the A&P of postpartum, that overdistended uterus, anesthesia or analgesia, history of uterine atony in previous pregnancies, high parity, prolonged labor or oxytocin induction, and the trauma. If she's had an operative delivery, operative abdominal is our C-section, but an operative vaginal delivery is using forceps to help deliver this baby and or using a vacuum extractor to help deliver this baby. How do we prevent this? One, prevent that bladder distension. Help her get up and go to the bathroom. Remind her how important it is to keep emptying her bladder. Provide an ice pack to her perineum in the early postpartum period to prevent swelling that's going to make urination very difficult if all her tissues are swollen. And then catheterize if necessary. Well, it's 6 hours, I'm going to give her a little bit longer. It's 6.5 hours, I'm going to give her a little bit longer. It's 7 hours, I'm going to give her a little bit longer. She has 6 hours. If she hasn't voided, and we've done everything we can to help her void, the water in the bathroom, the upambulating, the water over her perineum, then we need to catheterize her. What else can cause bleeding in our postpartum time frame? We need to suspect a pelvic hematoma if our mom is telling us that she has rectal pressure, vaginal pressure, perineal pressure, or pain. Any of those symptoms could be indicating that she's got a pelvic hematoma. If we see perineal, pelvic, or rectal swelling, bruising, or bulging, then we need to make sure we notify our provider. They may need to come in and evaluate this. We would suspect a hematoma because of this increased pain, because of this increased pressure, and she's showing signs of blood loss, yet her fundus is firm. A late postpartum hemorrhage that occurs after 24 hours up through 6 weeks after delivery can cause profound onset of shock. In previous lectures, we've talked about how well mom can compensate if she's having some blood loss, so we don't have a big change in vital signs until very, very late. Please remember that this hemorrhage can happen out to about 6 weeks postpartum. By that time, she's lost all that extra volume. She no longer has that vasodilation of pregnancy, so her vascular system has already vasoconstricted, so she doesn't have those kind of compensatory mechanisms anymore. So this can be a rapid onset. And what causes this is we either have retained placental fragments, subinvolution where that uterus just doesn't clamp back down like it's supposed to, an infection, or unrepaired lacerations. What are we going to do in the postpartum time frame to prevent this excess bleeding? Our assessment. We're going to continue to do our fundal massage. If she gets soft or boggy in between our assessments, then we need to think about increasing the medications that we're giving her. And those medications are called oxytotics, meaning that it's going to help that uterus contract. Now, in the postpartum or in labor and delivery, we talked about giving very small doses and increasing the Pitocin by very small amounts. In our postpartum time frame, we can give a big bolus of that Pitocin. We're very concerned while she's still pregnant because we don't want that uterus to clamp down, because if it does, It can cause a uterine rupture if it still has a fetus in it. It can cause a placental abruption. We don't want that if there's still a baby in that uterus. Those aren't concerns now in our postpartum time frame. We do want that uterus to clamp down. So we're going to bolus her with 250, 500 mLs of a solution that has about 20 units of PID in it. We can give hemabate if our Pitocin isn't working. We can give Methergin. Methergin we want to be very careful of because it's contraindicated in our women that have any form of hypertension or cardiovascular disease. Because while it clamps down the uterus, it's also a vasoconstrictor. And then breastfeed if mom's breastfeeding. That breastfeeding is nature's oxytonic. Massage and breastfeeding we've already talked about. Bimanual massage and compression. That's where we have our hand on the top of the uterus. We have a hand at the bottom. Sometimes we have to do this from an internal and external way to help prevent postpartum hemorrhage. We're going to give our oxytocin that we've talked about, our Pitocin. We're going to give our Methergin, ergometrin. We used to use quite a bit more. It has some serious side effects, so I don't see this used quite as much anymore. Our prostaglandin F2 alpha, which is hemabate, which we just got done talking about. I do know some of the docs in some of our facilities actually put a Cytotec pill in the uterus during a C-section to help clamp that down as precaution, as a prophylactic method to prevent a postpartum hemorrhage. And as an absolute last resort, we may have to do a hysterectomy in order to prevent life-threatening bleeding. Let's review. What is causing our bleeding? It's our uterus if we have a boggy fundus, if the loci is dark and it diminishes with massage or oxytotics. It's probably a laceration if we have a firm fundus. If we have a firm fundus, we do not have uterine atony. Our laceration is going to be frank, bright red bleeding as opposed to our dark lochia if this is a uterine bleed. Remember that if mom's been laying in bed for several hours, when you go to sit her up and stand her up and walk her to the bathroom, she's liable to have this flood of lochia. And we have to make sure that we don't panic thinking that she's hemorrhaging. It just means things have pooled in her vaginal vault while she's been laying down, and now when she stands up, gravity says, let's get out of here. The first E in our bubble is our episiotomy. We want to roll mom to her side, separate her buttocks to visualize her perineum. The best way to check her perineum is from behind. So we get her over on her side. We tell her to put her upper knee, the knee that's on the leg that's on the top. We want her to lay it over up on the bed as far as she can get it up and over on the bed. When she does that, she kind of opens up her buttocks a little bit and allows us to see her perineum a little bit better. That's also when we can check for hemorrhoids. Be careful as you lift her buttocks because her bottom is very, very sore. If she's got an episiotomy, if she has a laceration, if you yank her buttocks up, you're just putting tension on that laceration or those suture lines. So be very careful. This is also a good way to check for hematomas. See if the labia looks like it's swollen. Does it look like she's got a bulging near her rectum? If applicable, we also need to assess her cesarean incision. We want to teach her about her peribottle, changing her pad, wiping from front to back, wipe gently. We want to teach her about using a sitz bath. The first 24 hours after delivery, we're going to put an ice pack on her. And then after 24 hours, we're going to have her in a warm sitz bath. And that's a little basin that she can actually put in the toilet. We fill it full of warm water. It has a bag that's attached to it, kind of like an enema bag or a feeding tube bag is above that. Fill that full of warm water. She sits in this basin with this warm water. We open the clamp on our bag and it allows more water to flow in. So that water's continuously being replaced as it rinses her bottom. That heat helps heal. And the reason it helps heal is because it increases blood circulation because of how warm it is. They also have dermablast spray. Every hospital has its own, but something to help numb their bottom. Perineal lacerations, we have 4 different types: first, second, third, and fourth degree lacerations. First degree means it extends through the skin and the superficial structures to the muscle. Second degree extends through the muscles of the perineum. Third degree continues through the anal sphincter. And then a fourth degree extends through the anterior rectal wall. So vagina and rectum at one point were one. And they've had to go in and suture that to separate those two again. Our third and our fourth degree lacerations should have no rectal suppositories because those have been sutured, and to put a suppository in means that you could very easily disrupt those sutures. Sometimes our moms might have a vaginal sidewall laceration. Sometimes those are sutured if they're significant enough. Sometimes we're just going to watch and see how much lochia they have, how much perineal bleeding they have. And then sometimes we have periurethral lacerations where the urethra has a tiny little laceration in it. Sometimes they have to suture that, sometimes they don't. But know that if she has a periurethral laceration, it means that peeing is probably going to be painful because she has this laceration and that urine's going to burn. Depending on the significance of this periurethral laceration, they may go ahead and catheter her in labor and delivery before or after they've sutured that laceration because we know she's going to swell. So we'll keep her catheterized for about 24 hours. Assessing our incision, remember your Rita from Med-Surg. A lot of times our students in OB think of this only in looking at their perineal laceration. Remember, this is also to assess the C-section incision on their abdomen. Risk factors for a laceration obviously are big babies. Remember our shoulder dystocia that we talked about last week. Sometimes we have to cut an episiotomy and it can extend with a laceration because our baby's too big or because of the difficulty in the delivery. A rapid delivery. There's a reason labor takes time. It takes time to help move, soften, and stretch those tissues to get them out of the way for delivery. And so if baby just kind of comes running through there like a bull in a china cupboard, then it can cause some lacerations. If we've had an operative vaginal delivery, our vacuum extractor or our forceps. If this is a first-time mom, the reason they're at risk is this tissue hasn't been stretched like it has been if she's delivered in the past. Congenital abnormalities of mom's soft parts. Any part of the tissues of her pelvis, if there's a congenital abnormality, can increase the risk of lacerations. Contracted pelvis, difference in pelvic bone structure, and then the skill level of the attendant. If you remember from L&D, we talked about supporting that perineum during delivery so that we decrease the risk of our lacerations. If we have vaginal bleeding in the presence of a firm fundus, we need to suspect a laceration. How do we fix lacerations? Surgical repair, ice to the perineum for 24 hours, sitz bath after 24 hours, and then analgesics as needed. Our assessment schedule on postpartum. Every hospital is going to have their own policy. So you need to make sure you're doing what your hospital policy says. Sometimes they're every 15 minutes in recovery down on L&D. And once they're stable on L&D, and they get transferred to postpartum, then we do a full assessment as she gets admitted. And then every 4 hours or every shift if she's stable, or as needed based on signs and symptoms and complaints that mom have. All right, we're done with this section. Let's take a brain break, and then we're going to come back and talk about our postpartum teaching that we do for our moms.